Right, let's take a look at this slide right here. In terms of the ventilation and external and internal respiration. Ventilation is the actual movement of air in and out. So when we ventilate somebody, you're actually moving the air for them. Sometimes we're bagging them, and again, right, when you're doing some kind of general surgery, everything's paralyzed. The movement is also, especially the diaphragm, does not move. All skeletal muscles are paralyzed. The diaphragm is a skeletal muscle. So we will have to ventilate them by giving them either bagged air, or we give them, basically, we have to intubate them and then put them on a ventilator. External, internal respiration is our gas exchange. So internal means you're moving the red blood cells into the tissues, and then you have to exchange the gases in the tissues. That's an internal respiration. External respiration is when you have gas exchange in the lungs. Keep in mind that there's a big difference between what happens in the lungs and what happens in the systemic tissue. So there's always a huge change. In terms of respiratory system, some of these we know, it kind of makes sense. In the nose, when you take a deep breath in, you'll smell something. We know that in terms of the respiratory system, you will have your vocal cords. We'll talk about how that produces sound. The ones that we don't really understand or haven't talked about much is pH. Now, there's one big thing about pH that's important, and that is, and it's not about oxygen. Keep in mind that in terms of pH, this really important chemical equation is incredibly important for both carbon dioxide production and carbonic acid and bicarbonate. This is how our respirations affects our blood pH. Again, remember just a little bit about our general chemistry. The more starting material you have, the more you push the reaction to the right, the more final product we have. So by increasing the amount of carbon dioxide, we push the carbon dioxide bicarbonate reaction to the right, and you produce a lot more of the acids. And hydrogen, and the concentration of hydrogen is a measure of the pH. So the higher the concentration of hydrogen, there's an inverse relationship with pH. The higher the concentration of hydrogen, the lower the pH. Inverse means that they're going in opposite directions. When there's a direct relation, the higher it goes, the higher the pH goes. That's not what happens. Right? So there's an inverse relationship between hydrogen concentration and acidity. The more hydrogens, the more acidic something becomes. What produces this hydrogen? More carbon dioxide. How do we control carbon dioxide? Increasing or decreasing your respiration. So this is how regulation of blood pH works here. And we're going to see that sometimes it can cause a problem. Other times it can be a way of compensating for a problem. What else? Production of chemical mediators. ACE. We're going to start talking about this a lot more. ACE is angiotensin converting enzyme. What it's going to do is take something that is a precursor, and then we're going to activate it in the lungs to make it even stronger. So when do you want something that is going to increase your blood pressure, like ACE will? When you have low blood pressure, when you have dehydration, that kind of stuff, well, you need to pressurize blood for it to move. When the blood pressure starts to drop because of the amount of water you have in a body, you start sweating. You're at Summerfest, and there's a big line in a water bubbler, and then they're charging you what, $5 for for like a 12-ounce water bottle, and now you're not drinking much. So what happens? You've been there all day dancing around, and you're going to be exhausted and dehydrated when you get home. So your body has to sustain blood pressure though. How does it do so? Activates ACE, which activates angiotensin. And then you're going to see some other hormones get released as well. And what we're eventually going to see is the body trying to cope with that decreased blood pressure due to decreased water volume. Now, important thing to note is just the type of cells that we see here. So when you're talking about the pharynx, there's three components, right? There's one that starts at the nose, the nasopharynx. That's this region right over here. Included is that the adenoids. So I want you to know the type of cells that are found in the nasopharynx, because there will be a switch. And it helps us kind of understand why in our class, in 201, I had you guys memorize so many of these cells. Why? It's because we see it again. The nasopharynx contain ciliated simple columnar epithelium. So, and sometimes pseudostratified columnar epithelium. The big one is that you can have a lot of cilia, and every now and then you're gonna have a lot of goblet cells. Those goblet cells are mucus-producing cells. So in the nose, you're not normally putting food in your nose, right? So you don't need protection from the food. We have what's called this kind of respiratory epithelium. We're gonna see this pseudostratified ciliated columnar with goblet cells in other areas of the respiratory system. We're gonna see it in the trachea. We're gonna see it in the bronchi. We're gonna see it all over the place. But we see at the start in the nasopharynx, and then in the oropharynx region, there's a switch to stratified squamous. So these stratified squamous cells do not have a lot of keratin in it, because keratin is drying. Think about your skin when it's cracked, and you have all that keratin that kind of develops. You guys have all gotten a sore throat. And then in the middle of the night, when you have a sore throat, you wake up and you try to drink some water, and it just burns because it's so dry, right? So we don't want something drying in our throat. So we have the moist version of the stratified squamous. And again, why do we need stratified squamous? Is that you have a transition between now just air coming in the nose to now air and food going through. And if you remember, food can be hot, it can be full of bones, it can be sharp. And what happens is you are going to need protection. The laryngopharynx is a continuation, and this is where we split, so now air only goes up front, food goes to the back. In the laryngopharynx, as it's continuous with the mouth, what happens is you will have food that has to go through there as well. So you have the moist stratified squamous epithelium. At this point, we start to deviate and bifurcate, split in two. So here's the larynx. Again, pharynx is your throat. Larynx is the whole structure, including the thyroid, including the cricoid, including the vocal cords. That whole area, once we start to divide, is called the larynx. Now, who's ever seen somebody with like that electrical voice box? So usually when people have cancers of the throat, and they have to kind of remove some of the tissue there, they have to remove the vocal cords. Now, if you've ever seen people actually talk through that, now thank goodness we don't see it as much, because I don't think we have as many people smoking cigarettes anymore. Obviously, a lot of young people are smoking their electric cigarettes, and we're gonna see, remember, people were smoking for hundreds and thousands of years before we had enough evidence saying that it's bad and that it can cause a lot more cancers. We've only had e-cigarettes for, half a decade? Maybe 10 years at the very, right? So we don't have any kind of time frame, any kind of studies that has shown what happens if you've been smoking this. The one thing I'll keep you guys kind of alerted on is whenever you introduce an insult into the lungs, it will cause problems. Whether the insult itself is going to be from cigarette smoke, or asbestos, or just normal pollution. There's a reason why you will see in the cities huge amounts of kids and adults with asthma compared to in the countryside. Now, take in fact the socioeconomic barriers that we see here. There's a huge numbers of kids in the whole world, it's not just in America. A lot of them in the large cities have asthma, and the reason for it is the kind of cumulative effect of the pollution we see in the large cities. right? So think about, in terms of these cartilages, review those. Let's talk about the functions of the larynx and how we produce sound. The larynx allows only for air movement in and out. The epiglottis, vestibular fold, prevents swallowed material from going into the larynx. Vocal cords are primary source of sound production. The greater the amplitude of vibration, the louder the sound. Frequency of vibration determines the pitch. How do we change the frequency? Remember, when we're looking at sound right here, let me see that they don't have it. I don't put that on here for some reason, but in terms of sound, when you have the slowly moving waves of sound, that is your more basic lower sound, right? So when you hear people singing with a low voice, what happens? Sound waves are produced, but the sound waves are vibrating slowly. They're oscillating back and forth really slowly. So the frequency is very, very low. That our brain interpret that as that low, very bass sound. Now, high frequency is going to be how fast the waves moves back and forth, how it oscillates quickly. The faster sound waves oscillates, the faster, right? And the higher the frequency, the higher the pitch, the more soprano sounds we have. The louder something is the movement of the waves itself. How fast, how big does it oscillate back and forth? That allows us to have that actual amplitude or loudness. You probably have heard that people have tried to break glass, right? And the reason why glass can break is because all matter has a little bit of resonance, and the higher the pitch, the louder it is as well, causes glass to really vibrate and eventually, with help, usually break. Yes?
So with high frequency, the length of the wave, the amplitude is shorter?
Yep. The amplitude it can be big. The amplitude is how fast it goes. So we're talking about, imagine if this right? It goes back and forth, oscillating like this, right? So for fast ones, it oscillates back and forth real quickly. Sometimes, if it's loud and fast, or loud and high pitch, it can go up like this, right? That means it's both higher in amplitude, and because it's going, the higher in amplitude, that's loudness, because it's also going back and forth so quickly, that's higher pitch, and more powerful and increased loudness. Now, how do we do this then? How we do this is by the tension in the vocal cords. The more you tense the vocal cords, the tighter, and I want you to think the vocal cords are like strings, right? Now what happens if you kind of vibrate the strings on a guitar, and the guitar strings are really heavy, it's really thick? What happens is it oscillates slower, right? That's why the bigger the strings of guitar, the vibration starts to slow down. If you've seen a bass guitar, they're all big strings. Now, the lower and the smaller the caliber of the strings, the more it can vibrate faster, right? We are able to change pitch because we're able to create tension. As we create tension, what happens? Well, we create tension, then the string of our vocal cords get pulled really tight. As it gets pulled really tight, it's going to vibrate faster, right? Now, if you're singing really loud, it's going to vibrate faster and with more amplitude, giving you that really nice, loud soprano voice that you might hear in people that are classically trained opera singers, right? Now, the real basic sound, keep in mind, there's a level at which, right, we're all different, and that's okay. So if you think of a typical male and a typical female, typical male can get, their voice is going to be a little bit lower. And if you hear a female kind of talk really, really deep, sometimes it kind of, takes you by surprise, right? Or you hear a male talking really, really high, like Mike Tyson, right? Sometimes it takes you by surprise, right? So within everybody's parameters, there's an ability to change pitch, right? So if you're a male, you're not gonna hit those high notes because your, vocal cords are gonna be a little bit more taut. Your vocal cords are gonna be a little thicker. It's like having the big bass guitar type of strings, right? Yeah, you can kind of, oscillate as fast as you can, but you're limited because those strings are so big. Try it like a male vocal cord, right? Female vocal cords are a little bit thinner. It's a little bit, right, because of the angle of the thyroid cartilage. It's not as, kind of acute, all right? So it's not quite as pulled, taut and everything. So then they can get the high pitch, but they're not usually gonna get the low pitch like a male can. So these are the true vocal cords right here. The space between the true vocal cords is called the rima glottitis. I know it's really hard to actually tag the rima glottitis, but this space between the true vocal cords is called the rima glottitis, and it's a space where air enters your trachea. So in terms of when the structures of voice production, air is passed through a tight ligament. Tighter the ligament, the higher the pitch. To increase volume, you need to create more air movement. Male vocal cords are thicker and longer, so they normally vibrate more slowly. And for males, because of testosterone and estrogen, what happens is that, when they hit puberty, there is a noticeable change as the thyroid cartilage becomes more prominent, right? Take a look. If you've ever seen, if you think of an 8-year-old little boy, have you ever seen an 8, 9-year-old little boy with a real pronounced Adam's apple? Right? So that happens at puberty. It'd be kind of weird if you do, right? You see a little baby with a real pronounced Adam's apple, right? So, that happens a little bit later. As air goes past the larynx, it goes into the trachea. C-shaped rings, and remember, it's C-shaped for a reason. The reason is behind the trachea, you're gonna see the esophagus. When you swallow, food goes down as big chunks or boluses, right? And as you move that food down, that food is kind of squeezed down from one section to the next. Since it's right behind the trachea, if you didn't have the trachealis, every time you would swallow anything and you're squeezing it down, there's a bulge, right, in the esophagus. As there's a bulge in the esophagus, if there's an O-shaped ring, that bulge will cause movement of the trachea to the front every time. The C-shaped rings allows you to have this bolus, and instead of pushing the cartilage forward, you can just kind of indent into the trachealis. Again, that doesn't matter because you can't swallow and breathe at the same time anyways. Here's the trachealis, and here's how close the esophagus is to that trachealis. You can imagine if there's a big bolus of food you're swallowing, you guys are about taking a bigger bite than you want it, right? And then you're like, oh my God, I hope I don't choke, right? You always have to make sure you get it down. You guys understand, when we think about swallowing food, how long do you think it takes between when you swallow and when it hits the stomach? Maybe 1 or 2 seconds, right? It takes about 4 seconds. And what happens is it takes time. Now you actively don't have to think about swallowing normally. You start the process and then smooth muscles eventually take over. But that doesn't mean it doesn't require time. Now take a look at the trachea and what kind of cells we see? Pseudostratified, ciliated, columnar with lots of mucus producing goblet cells. Up until a certain point, mucus is pretty helpful, right? Mucus allows you in your nose, traps odor molecules so then we can smell. Keep in mind, all the gases that can be very dangerous, we can't see. So if you think of hydrogen sulfide, you can't see that. Even methane, you can't see. So what happens? Well, true natural gas has no smell to it. So to make sure that there are gas leaks, we actually have to add mercaptan in there. And you guys have probably been driving around and you notice something is leaking, right? and you try to get away as fast as possible. And what happens is it doesn't take much of that mercaptan to be released for us to notice it. And that's a way that our body has of just kind of making sure that your brain understands that even though you can't see it, there is something in our environment that may cause harm. So we need a little bit of mucus to trap those odorant molecules in the nose. This mucus right here in the throat is there to catch, hopefully, any kind of dust particles, and it traps it. As it traps it, this mucus gets a little bit thicker, and now the cilia helps move all that mucus upwards. Again, right, I don't know what's worse. If I'm sitting next to somebody and they keep clearing their throat, or I'm sitting next to somebody, they keep clearing their throat and they keep spitting it out. It's pretty gross either ways, right? I mean, it's natural, it's just not a great thing to have to think about. All right, so, I mean, when people clear their throat, usually all that trapped particles goes up because of the cilia, and then it goes past the epiglottis, and then you swallow it down. All right, that sounds great, doesn't it? I don't know what sounds worse. Like you actually have it go up, and then you spit it out, right? At least one way you're not bothering anybody. So this tracheobronchial tree right here, again, here's a trachea. And what we're going to see is that at the very start of our respiratory system, it's almost all cartilage. The main purpose is to make sure you're always having air movement. Again, take a look on the left. The left bronchi, primary bronchi, actually splits first. So I remember when I first started intubating people when I was doing my residency. One of the things that does happen is when I put the tube in, and you think it's pretty long by looking at this, right? So you think, oh, there's no way I pushed in that far, the tube. But what happens is the left lung and the left primary bronchi actually is going to deviate first. So as it deviates first, there's a chance that I actually take that tube, we want to hit it in the trachea and keep it in the trachea. If we have it in the trachea, both lungs should be fully ventilated. But because of that deviation of that left bronchi first, sometimes all it needs is just a little bit extra push, right? And then the tube doesn't go to both lungs, it just goes to the left lung. Yes?
How far down does the tube go?
It depends on the person, right? So if we want it to go, right, best case scenario, we want to go right in that middle area right here. So that air would move into both primary bronchi.
Where's the blade used? The intubation blade?
The intubation blade is going to be right underneath your tongue as you elevate so the whole purpose of the intubation blade is to elevate the mouth, the lower jaw, so then you can visualize the vocal cords. And again, if you have somebody that's heavy, that's actually hard to do. And I'm not talking about, you're 190 pounds and you should be 140. I'm talking about you're like 400 pounds and you should be at 140, right? That's when even good anesthesiologists might need a scope to take a look at it. The secondary bronchi, 2 on the left, 3 on the right. Some of these models, right? You have to look very carefully to see that third secondary bronchi on the right. So keep in mind, there should be 3, but some of them only show 2. So we have a anatomy model for anatomy class that's not anatomically correct, right? So keep in mind. As tubes, so we go from like these large trachea, splits into 2 smaller primary bronchi. As the primary bronchi then shifts air, we shift it into the secondary, leading to the lobes. Air is still moving too fast, so then we're going to split it into the tertiary bronchi. The tertiary bronchi eventually leads to bronchioles. Right? Bronchioles right here are different. Bronchioles, usually that's a split. Before that, we have a lot of cartilage, making sure that air always moves in and out. In the bronchiolar level, you start replacing the cartilage with smooth muscle. So when you have somebody that's coughing a lot, it is a bronchiolar spasm that causes that cough. So the bronchioles, going to be made out of smooth muscle, and as the tubes become smaller and smaller, the amount of cartilage decreases and the amount of smooth muscle increases. All right, from the tertiary bronchi to the bronchioles, there's a switch to only smooth muscle. The weird thing is this. You think terminal bronchioles. They're terminal. They're the end. It's not true. So it's another one of those kind of, questions that can be confusing. So which are the most distal bronchioles? Meaning the ones closest to where we're actually having gas exchange. Not the terminal, but the respiratory bronchioles. So respiratory bronchioles are the very last vestiges of smooth muscle. That main job is to funnel air. All we have done is funneled air from a larger structure to many, many smaller structures. Air going into the primary bronchi is moving way too fast for gas exchange to occur. So we need to slow it down, and we slow it down by diverting it to different areas. By the time we hit the respiratory bronchioles, we're going to then see just these bubble-like cells, or clusters of cells, called alveoli. So these are the alveolar cells right here. And if you take a look at this, these alveolar cells on one side, I want you to think about this as like a cluster of balloons. As air goes into the balloon, it's going to fill up the balloon. As you fill up the balloon, you thin out the latex in the balloon. So if the balloon gets overly filled, the latex cannot keep its integrity and it ruptures. So if you've ever seen somebody try to fill a balloon, it ruptures, that's what happens. Now, in our body, we don't do that. Not unless we have some massive issues from smoking or something. So in our body, what happens is as air goes into these alveolar cells, the alveolar cells, just like a balloon, gets pushed open. All right, the bigger it gets, the thinner the membrane becomes for air to go through. Now, why is that important? Because air is on this side right here, on the internal structure, while your blood vessels and your capillaries are on the outside. So I want you to imagine that it's like a balloon, right? But on the outside of the balloon are where your capillaries are. So how can we ensure a much easier passage of gases, right? Because it's got to go through the balloon itself, right? Gas is coming from the inside, the balloon gets opened, and now you have the capillaries on the outside. The more open the balloon, the easier it is to get gases from the inside out through the cells of the alveolar and then into the capillaries. So there's always some kind of membrane in the way. Always. That membrane that's in the way is what we call the respiratory membrane right here. Right? Again, keep in mind just about everything we've mentioned, except now we're going to talk about the alveoli. Everything else, the main purpose is just to funnel air into different areas. Nothing has happened in terms of gas exchange. Right? You don't have gas exchange in the aorta, right? You don't have gas exchange in the superior mesenteric artery. Too much and too fast of movement of blood in those areas. Same thing here. But what we are going to do now is split into smaller and smaller regions, slow down the air movement. By the time it gets into the respiratory bronchioles, the last directed kind of air area, now we can funnel it into the alveolar cells. Now we can blow it up. Now air is going to accumulate in that balloon, and now the balloon is spread out, the membrane has thinned out, and now there's easier gas exchange. Now what are all right, so when you take a look at this picture right here in slide 19, you'll notice that we have two main types of cells. Type 1 pneumocytes, type 2 pneumocytes. Again, keep in mind, air's coming in from the inside of our balloon. Your capillaries on the outside of the latex. So that, all right, there's never direct contact between the red blood cells in the capillaries and the air you're bringing in. Air always has to go through some kind of membrane. The membrane is made out of the actual cells here. So remember, endothelial cells, right? They help form a membrane, and then gases have to go through the endothelial cells in a capillary. Same thing here, right? As air goes into this area, the cells that form the alveoli, well, those cells get spread open. They thin out the membrane. As they thin out, it makes it easier for gases to go from inside here into the capillaries. Right, so the type 1 pneumocytes are actually thin, simple, squamous epithelial cells. Forms 90% of the surface of the alveoli. And usually we have a few type 1 cells, right, that actually help make up one alveoli. Right, so type 1 cells are the actual cells that form the balloons of our alveoli. Type 2 cells are very important. Right? You guys have all tried to blow into a very small balloon versus a very big balloon. There's a big difference, isn't there? If you have a very small balloon, it's really hard to get the first couple breaths in because there's so much surface tension in that latex. Our body undergoes the same process. Right? Now, what happens when you try to blow into a very small balloon? You start to stretch it a little bit, right? What you're trying to do is actually destroy some of that surface tension to make it easier to blow into the balloon. Now, the problem in our body is we can't really stretch it out physically, right? Because it's internal. So what do we have instead to kind of decrease the surface tension are these cells producing surfactant. Surfactant is like a detergent, and what its main job is to decrease the surface tension, so then when air comes in, it makes it easier to blow up the alveolar cells. As it blows it up a little bit, the more inflated that region becomes, the more you thin out the membrane, the plasma membrane formed by the alveolar cells. Right? Now, type 2 pneumocytes surfactant also prevents the collapse of alveoli with each expiration. What happens when you have a balloon that's fully inflated? You have your finger on that, the nozzle, and then you release it. All that air wants to come out because of recoil. So this is also the same thing, right? There's going to be kind of air moving out because of recoil, because you have now blown up our alveolar cells. They want to recoil and then expel air. Surfactant prevents that. And what we're going to see is, right, kids that are born premature. Again, the liver, the lungs, has never had to be functional in utero. So even though, you might have a child that is almost normal in terms of time, right, they might not have a fully mature liver because they never had to use it. Mom takes care of everything. There's no air in the uterus and the womb, so there's no way there's even any air movement into the lungs. So what we notice is this, right, when kids are born premature, they have a harder time opening up the alveolar cells, right? And because of that, most of the time we have to, in the old days, the only thing we could do, old days like in the mid-50s and 60s, one thing we could do is give them lots of oxygen in a very, high atmospheric state, right? So you have to force oxygen into the lungs, and the oxygen forces these alveolar cells open, and then with each exhale, the whole thing collapses again, all right? As the whole thing collapses again, you gotta have that forced oxygen, opening it up again, right? What happens? Well, those kids started getting a little oxygen toxicity, all right? And they started to go blind because there's accumulation of oxygen bubbles that started occurring in the retina cells. What really happened afterwards was that we started doing and producing our own surfactant. So the surfactant that we can make now allows kids to stay alive up until we see the edge of viability is about 24 weeks now. At that point, right, the brain has somewhat matured, it can develop outside. The lungs have definitely not matured. So if we had surfactant, we can keep them alive. And usually if you're giving birth to a baby at 24 weeks, right, the baby is really small. So small you can probably hold the baby on your hands. And our man-made surfactant is something that has been a game changer.
say the surfactant was what was it?
Like a detergent that decreases its surface
So
tension.
it's not an enzyme, it's not an
No, it is like a protein.
protein?
Right, layers of the respiratory membrane. So in terms of the respiratory membrane, note the layers that are highlighted here. They make it a hindrance for oxygen to go from the alveolar cells. It has to go through the cell itself, forming the alveoli. Has to go through the basement membrane, keeping those cells of the alveoli together. Has to go through the basement membrane of the capillary, keeping those capillary endothelial cells together. And then it's got to go through the simple squamous epithelium that makes up the capillaries. Right? If there's any thickening here, right, any kind of fibrosis, then you have a membrane that's much thicker than normal. What happens is gas exchange is going to be slowed down tremendously. And again, just review this, that not only is there a change in the cartilage to smooth muscle, but there's a change from pseudostratified ciliated columnar in the bronchi to bronchial at the bronchial level to just simple cuboidal at the bronchial level as we pass deeper in the lungs. Now again, we're gonna see smooth muscle in our arterioles. We're gonna see smooth muscle in our arteries and the tunica media. We're gonna see smooth muscle here in the bronchioles. The smooth muscle of the bronchioles keep your bronchioles either dilated or constricted. And what happens is the smooth muscle in the different area of your body has different kind of effect from usually even the same type of hormone. Meaning if I put a hormone or if I put a protein in your body, like epinephrine and norepinephrine, I know, for some reason the door's not locking. So I put epinephrine or norepinephrine into your body. That epinephrine, if it's in the bloodstream, will cause widespread vasoconstriction by way of the smooth muscle. Smooth muscles constrict usually in response to epinephrine. If I put that same epinephrine in your lungs, we also see smooth muscle in the bronchioles, but the opposite effect occurs. Instead of constricting in the lungs, they dilate. That's why albuterol works. Remember, albuterol is a beta adrenergic. It acts like epinephrine, except you inhale it and hopefully it stays in the lungs. Right? That epinephrine-like material that we call albuterol, well, that albuterol in the lungs, what does it do? It causes your bronchioles to dilate. Just about the same type of medicine, two different effects. One effect in the circulatory system causes constriction of the smooth muscle. The opposite effect in the lungs. If you release epinephrine in your lungs, what's going to happen? You bronchodilate. By the way, this is why when we have anaphylactic shock, why epinephrine is so effective and why you need to carry an EpiPen. The reason is it gets rid of the two things that might kill you when you're in anaphylactic shock. Gets rid of the widespread vasodilation and the drop in blood pressure. That can kill you, right? Obviously, if you're in anaphylactic shock, there's no air moving in as well, and you have bronchial constriction. That can kill you as well. If you give somebody epinephrine bronchodilates. Now air can move. Epinephrine vasoconstricts. Now you can increase blood pressure. Both is what we need. So keep in mind that, in terms of these smooth muscles, whether we're talking about the lungs or we're talking about the whole circulatory system instead of the lungs, right? Systemic versus pulmonary. Epinephrine is different. Right, now comes the fun part, inspiration and expiration. Keep in mind that we all follow this rule of Boyle's law. In Boyle's law, we discuss this. The difference between pressure, the relationship between pressure and volume. All right? So there's an inverse relationship. As a volume increases, the pressure drops. and vice versa. Now, I want you to think about it this way. You guys are probably gonna go to, have some kind of barbecue tomorrow. And nowadays everybody uses propane, right? So that's okay, right? When you buy propane and you buy 10 gallons of propane and you put it in a 10-gallon tank, that's pretty pressurized, isn't it? Now what happens if you take that same amount of propane, 10 gallons, and you put it in a 100-gallon tank? I've increased the volume of that holding tank, haven't I? What happens to the pressure? It's gonna drop. By changing the amount of the volume, there will be an associated pressure drop. Now, why is this important and how come it relates to our body? Simple. As we take a deep breath in, the deeper the breath you take, the larger the volume of your thorax. As your thoracic cavity increases in volume, what happens to the pressure in your thorax and inside? There's a pressure drop. Right? As there's a drop in pressure, now there's more pressure in the environment than it's seen in the lungs. Air always moves from higher pressure to lower pressure, right? And that's exactly what happens. The deeper the breath, the deeper the volume increase, the deeper the drop in pressure, the more air that moves in. Now, the same thing is also true when we exhale. When you exhale, what happens? Right? The volume decreases. Along with the recoil of the alveolar cells, there's going to be a noticeable increase in pressure as well, allowing you to exhale. Now, there are things we can do to move air in and out faster. If you guys have been, playing sports, I always tell you to put your hands over your head as you keep walking and cooling down. You see this all the time in basketball players. You don't see it many times in football players because, especially the pro athletes, they're going to have oxygen mask available for them. But high school athletes, you see that a lot in basketball and track, right? So when they're done running, they keep their arm up. And what does keeping their arm up do? They're able to take even deeper breaths with their arms elevated over their head. If you're able to take deeper breaths, you can get more air into your lungs, right? It's usually not as comfortable as the second way. The second way is, and you see this in basketball players all the time, they've been running a lot, and they put your hands on their knees like this. Coaches hate that for some reason, all right? For some reason. It's kind of like a sign of weakness for them, right? So they're kind of, tugging their shorts, and they're hunched over. We call this tripoding. What does tripoding do? Right? What it does is this. When you tripod like that, what happens to the size of my chest? It's naturally smaller, right? The volume's already decreased. What else do you notice? Right? When you're tripoding, if you take a look really closely, you can actually see the abdominal muscles work as well. So when you're tripoding, you are going to decrease the volume faster. As you decrease the volume faster, you increase the pressure in the lungs in a much faster rate. So then you exhale faster. And because you exhale faster, you can take your next breath faster, right? And now as you increase the breathing rate, you can get more oxygen into your body. Either ways works. There's a reason why most people prefer to do the tripoding is because it's a lot more comfortable. The problem is when you're tripoding, you usually have to stop, right? You can't walk around like this, right? Kind of weird, but you can't walk around like that and play defense because you're tired playing basketball. So coaches would rather have you kind of move with your arms up because you can still move around a little bit while you're taking deeper breaths. Now, we did talk about this in my other class, this saying that you will probably hear over and over again. C3, C4, C5 keeps you alive. The reason why is that those three spinal nerves that exit from the roots of C3, 4, and 5, they all merge together to form the phrenic nerve. The phrenic nerve is the only nerve that goes to your diaphragm. Right? If the diaphragm loses a phrenic nerve, it cannot activate the diaphragm. You will die unless you want to be intubated. Keep in mind, if you have that kind of spinal cord injury, not only will you be ventilated the rest of your life, you will also be paralyzed from the neck down. You'll also have no sensation from the neck down. Right? So it's one of those things where, you know, it's a tragic situation. I always use the story of my friend in high school who broke his neck when he was 17 years old. Right? And the weird thing is, you know, we were both wrestlers, so I was a sophomore, he was a junior, and he was already getting scouted for college football. And what happened was, I went out for, you know, a forced run. Right? When you're wrestling, you gotta be in shape, so we were all running, and they were having a wrestle off, and they're both heavyweights. All it took was just the combined weight to kind of, right, he fell on his head, and he actually had his spinal cord resected at C4, and he actually had to be intubated, right? And even now, he hasn't had mobility. Nowadays though, there's a little bit more acute treatment. So we are seeing it work a lot in that, right, it's not perfect. When people have spinal cord trauma now, what we notice is that you will go through an initial spinal cord shock where everything's gone, right? Once that initial spinal cord shock occurs, we need to make sure that the inflammation does not cause permanent damage. So what they did is actually cool the body temperature, right? And hypothermic therapy is now used so that we can decrease the movement of your inflammatory cells to that site. The first time I've seen it in like layman's terms was a football player for the Buffalo Bills in about 2011, 2010. And what happened was that first play of the year, kickoff, he had his head down. There's a reason why they tell you to keep your head up when you're making a tackle. And the reason why is this. When you have your head upwards, right here, I can't remove this one. Right, when you have your head up like this, what happens to your neck? Right? When your head's up, it's nice and bowed like this. Right? When your head's, alright, so when your head is up, it's like this, you can pass that shock of the impact from one vertebrae to the next without damaging. When your head is down like this, your neck kind of is bowed internally like this in a C shape. So when you hit something and your vertebrae is in a C shape, you're gonna rupture something here. And you're more permanently gonna have some kind of damage. Well, he had his neck down, he stopped breathing on the way to the ER. So we're talking about this football player that if they don't intubate him, he will die on the way to the ER. And the only saving grace was that there was a neurologist there that went to you know, like these conferences, and he knew that kid is gonna die. And they did thermic therapy. They cool his body temperature down to 85 degrees. All right, nowadays we want it to 80 degrees. As they cool it down, they do cold water, right? They do ice, they ice them up. They even do cold saline enemas to cool everything down. It worked, right? About